Thank you to everyone who's joining us. Indeed, important healthcare coverage, and we're very pleased to bring this media briefing today from the Ontario Medical Association. And I'll be introducing my colleagues as we get started. So thank you to everyone who's just joined. I'm at about 30, so I'll just look for the nod, Emily, maybe to get started. And welcome everyone to the Zoom room. We'll pop up the agenda and so you can follow along. So thank you very much for joining us for our latest media briefing on important healthcare issues in the news. And my name is Dr. Rose Zacharias. I am the president of the Ontario Medical Association, which represents more than 43,000 physicians in Ontario. Ontario is largely returning to pre-pandemic life this fall. We know our children will be back to school. I know my 4 children are anticipating that a bit reluctantly, but we do want to be prepared from a healthcare provider point of view. There is no mask mandate in place at this time, and many workers will also be back to the office in person. I know here at the OMA, we've been re-engaged with our hybrid model for a bit now and adjusting. But the pandemic is not over, and it seems that we will have to live with COVID-19 for the foreseeable future. We know that there will be additional challenges as we move into the fall and spend more time indoors, where respiratory viruses are more easily spread. In addition, we need to prepare for a potentially active flu season. We have known this in healthcare all the while. The fall comes and we prepare for flu season, but this is now post these 2 years, 2.5 years of the pandemic, and so it's an overlay of the stressors that we will deal with. So we want to be ready and be prepared. Surging in the Southern Hemisphere for the first time since before the pandemic began. What happens in countries such as Australia and South Africa is often a good indication of what will happen in Canada. And so that's why it's very important to get a flu shot this year, as well as your COVID shots. Vaccines remain the best protection against COVID-19, and Ontario has one of the highest COVID vaccination rates in the world. But the uptake in younger age groups has not been as strong as anticipated. According to Health Ontario, only 53.5% of children ages 5 to 11 have received at least 1 dose of a COVID vaccine. That's compared to 85% of the total eligible population. Children are also behind, we know this, on their routine immunizations. As many as 1 in 4 Canadian children have fallen behind in vaccines for things such as meningitis, hepatitis A and B, and measles, mumps. If not managed, we could see a re-emergence of previously eradicated diseases. For example, the U.S. Centers for Disease Control is investigating a possible polio outbreak in New York. These health concerns are coming at a time when hospitals are already overwhelmed, and I know I don't need to describe that situation to you. We are living it. In recent months, we have seen record numbers in our emergency departments, and some have had to close temporarily due to staffing shortages. We know from the past 2 years that COVID hospitalizations rise in the winter, as do admissions for the flu. And so that's why we need to implement solutions now that can help ease the burden on the healthcare system. So each of our medical experts today will elaborate on these issues from their particular areas of expertise. And I would like to introduce my colleagues and experts in the room. First of all, Dr. Zain Chagla is an associate professor at McMaster University and an infectious disease specialist at St. Joe's Healthcare Hamilton, where he heads a pilot program for outpatients with COVID-19 who are at risk of becoming seriously ill. Welcome, Dr. Chagla. Dr. Sloane Freeman is a pediatrician at St. Michael's Hospital and an assistant professor in the Department of Medicine at the University of Toronto. Welcome, Dr. Freeman. It's good to have you here as well. Dr. Andrew Petrosoniak is an emergency physician and trauma team leader at St. Michael's Hospital and an assistant professor in the Department of Medicine at the University of Toronto. Welcome, Dr. Petrosoniak. Dr. Chagla, can you please start by telling us what can we expect in terms of COVID spread in the fall and the winter, and what will flu season be like this year?
Hi, good morning, and thanks for that introduction. It's a big question of what is to come, as obviously this pandemic has had curveballs and surprises every 5 minutes, and so all we can go on is based on what we know today, but what we know tomorrow may be different. So in terms of the state of the pandemic right now in Ontario, we are seeing hospitalizations and intensive care stays. Thankfully, intensive care stays have actually not been a major issue over the last few months since the emergence of the first Omicron wave. Things have been fairly stable. Hospitalizations still remain fairly high, and that's largely due to the fact that the high community activity means high admissions with COVID, some of them with COVID, some of them for COVID, as well as unfortunately nosocomial activity in the hospitals as well. Deaths are thankfully lower, although approaching that of our BA2 wave that we saw in April of 2022. But thankfully, again, with vaccines and therapeutics have been much lower than we saw with Omicron, much lower than we saw at the beginning of the pandemic, and much lower than we saw at that period without vaccines. I'll flip to the next slide here. In terms of what's going on in our community now, I think we are starting to finally see that decline of the last wave, the BA4 wave, BA5 wave, the 7th wave, and we see it in wastewater signals. There's a stabilization of cases, although again, some of that reporting last week was also a bit skewed by the long weekend and testing behaviors of the long weekend. And so we saw a decline and then a little bit of a rise, which may just be a shift in cases for long weekend reporting, but generally stable in the component of people that are typically tested by PCR testing through the province. Next slide. This is some of the projections of what's going to happen in the fall from our local modeling group that we work with the city of Hamilton, as well as a company called Scarson to help with some of our modeling. And a lot of these inputs take into account vaccines, prior infections, waning immunity, and the components of the population that have been vaccinated more than anything else. So obviously a 18-year-old who's been vaccinated has a bit of a different healthcare utilization than a 60-year-old who's unvaccinated in that sense. The reality is, I think that we are starting to see the decline in healthcare utilization, probably continue for a good amount of time into the fall. As we would expect, as we have more indoor contacts, as the weather gets poorer, as we are more indoors, there will be a rise in case activity that also goes with waning immunity from prior infections that we've seen over the last few months, as well as waning immunity from vaccines. What may be a bit more different than some of the initial projections, I'll just go back to that slide, sorry. What may be a bit different than the prior projections is with this kind of summer wave, with a number of people that have been infected during the summer period, that does introduce some more immunity into the population that was not projected to be there in some of the modeling, looking at the summer where there was supposed to be very little activity. And so that may push that wave a bit further into the late fall, early winter, rather than kind of in the earlier fall where we typically see respiratory virus season starting in that sense. Next slide. Obviously, the big question of what could disrupt everything is variants of concern. And so, this is getting even more hard to track in the context of different global environments going through different phases of the pandemic at different times, and also having different levels of immunity to different virus. The two that are kind of on the horizon are this BA2.75 that was first described in India, that is causing some pandemic disruption in India. And you can see the bottom left here is India, seeing that BA.275 is now being overrepresented in terms of its samples. However, it's not really being represented anywhere else in the world significantly, and growth is pretty poor in other areas in the world. And so there's some questions of whether or not this was an India-specific phenomenon, particularly as much of that population had Delta back in April and May of 2021. And so this may be a variant that is much more in tune to infecting people that have had prior Delta infection as compared to much of the rest of the world where Omicron was their initial infection in that context. It is also important to note that actually in India, especially in urban areas like Delhi, that cases are actually receding as compared to increasing, although there was an increase that was seen over the last month. The other one that's on the horizon is BA4.6. It's been described more in the United States, particularly the Southwest. And you can see in the bottom right, the US sequencing in this little blue bar that seems to be increasing ever so slightly by week. And so, starting to represent itself as part of that BA4 chain. Again, in Ontario, they have been tracking BA4.6 for some time. And again, noted as far as week 14 when the old BA5, week week 14 when or week 18 when the BA4, BA5 started showing up. You can see as that yellowish line here, when you look at absolute numbers, though, the growth is not really being seen like it has been seen in the United States. And again, this really talks to the complexity of different variants emerging at different times with different immunities. The environment in one country versus another may not be predictable in terms of what happens here in Ontario going into the winter season. Next slide. Big question is obviously influenza, and this is looking at Australia, as Dr. Zacharias had mentioned, is often our canary in the coal mine of what's going to happen here as we have a switched winter season as well as similar surveillance. I wouldn't necessarily focus on absolute cases, as there's also been a significant change in testing as PCR testing has become much more available in the communities. Much more influenza will be diagnosed in the context of the tests for COVID or multiplex testing, which pick up COVID and influenza as part of their testing strategy. But what's important to know here is that there is a wave of influenza that looks a little bit different than prior years. So you see a very sharp incline where you would typically expect the incline, kind of the Australian fall, of a fairly high peak that happens very quickly over 4 to 6 weeks, and then a decline very quickly. Now, what happens, what's missing in this Australian flu season is the emergence of influenza B. So we have two influenzas that we typically see during the flu season: influenza A, which is typically H1N1, which all of us remember, and H3N2, which is kind of our early influenza season. And then that kind of January, February, March tail ends up being influenza B quite a bit. And that really is what kind of gets through the holiday season and gets us into January, February, and March. What's really interesting to see across the world is influenza B is not coming back after the pandemic, and very, very few cases that are being described globally. So, again, hard to predict what's going to happen in Ontario. I think we are going to see a flu season, considering, again, Australia had no flu seasons during the pandemic and had a fairly normal flu season going into this year, albeit a bit of a faster flu season in terms of when it turned off. And so, I think, again, with our globalization, global travel, everything back on the table, really does mean that flu will be introduced more in Ontario, emphasizing the need for people to get their influenza vaccine as part of this, because of the fact that it's going to not only be a protective measure for healthcare, but also reduce symptomatic febrile illnesses, which causes a whole myriad of issues in this day and age. But again, the season may be a little bit different than the prior seasons that we've seen in the past. Next slide. And so, there are lots of considerations of the fall, and I think even some of the questions coming in the chat around boosters and bivalent and univalent boosters, about influenza vaccines, and in fact, redeploying influenza therapeutics, which is something we forgot about for the last couple of years, but is going to have to be a part of making sure that high-risk people also have access to oseltamivir as part of their therapeutic management to keep them out of hospital. There's lots of questions about community isolation and how sustainable it is, especially in a respiratory season that is going to have several different people with febrile respiratory illnesses, in terms of how we isolate those individuals when we bring them back and how we exclude COVID as part of that. Access to testing, access to prevention and treatment, and really still important as we talk about health systems and preserving them going into the winter and the fall, that people who are high risk still need unfettered access to the therapies that we have to keep them out of hospital when they get COVID, and some novel therapeutics that are coming through the pipeline. Outbreak management and bed flow, and obviously we are starting to hear the emergence of other infectious diseases like monkeypox, polio virus, and even common infectious diseases like syphilis that are making a huge resurgence over the last few years that are causing health systems issues in the outpatient setting as well. And with that, I think I'll flip it back over to you, Dr. Zacharias.
Thank you so much, Dr. Chagla. I really appreciate your perspective, all these considerations. I know there are some more specific questions coming in the chat, and we'll give you some time to respond to those. But before we do, we'll continue just hearing from my colleagues in the room. Dr. Freeman, just turning over to you as far as like the pediatrics environment, back to school around the corner, children being behind in their routine vaccinations and such. Just really interested in hearing your perspective on how best to prepare for the fall.
Great, thanks so much for having me. So I want to highlight kind of two major concerns that we have with childhood immunizations since the pandemic. So the first is routine immunizations. Pediatricians, family physicians across the province are noting that children and families are not accessing healthcare the same way that they used to before the pandemic. And as a result, we are seeing that children are falling behind in their routine immunizations that would normally be given in infancy and early childhood. And these series are not being completed or not started, unfortunately. And so children are being under-vaccinated or unvaccinated. And why that's a concern is because then we start to see the reemergence of these vaccine-preventable diseases that otherwise we would never have thought of as posing a risk anymore. But for example, in the news, we all hear about polio virus being detected in wastewaters in New York City, in London, in Jerusalem. And this is really a concern for those that are under-vaccinated or unvaccinated. So just to emphasize, as we move forward through the pandemic, as things continue, we really have to focus on children maintaining and getting these routine immunizations that otherwise before we sort of took for granted. And also to say that we want children, especially this season, to get their flu vaccine as well. Similarly, we're seeing really, really low coverage in the Ontario school-based immunization program. So for children in grade 7, who normally receive their 3 immunizations in school in grade 7, prior to the pandemic, this was really quite well received, quite good coverage. 60 to 80% of Ontario children were receiving these grade 7 immunizations. Now, since the pandemic, so the last 2 years, these rates have plummeted. It's like below 20%, well below for some of these immunizations. And so, I mean, that's really a concern for our adolescent population for their futures. We really need to make sure that they get caught up and that these immunization programs continue and are well-resourced moving forward. And then finally, of course, the COVID-19 vaccine. So while Ontario has really nice high coverage for the population, it's this pediatric group, the children that are not well covered. They're not covered at the rates that we need and that we hope for. So for children 5 to 11 across the province, only 40% have completed the recommended series. So that's 2 doses for that age group, only 40%. For older kids, 12 and up, who are recommended to have the series of the 2 doses plus a booster, so the 3 doses, it's only at 20% across the province. So really, really low rates. And we really need to focus on increasing this for our children, especially as we move into fall. We think about back to school, being indoors. If COVID rates go up, we really want our children protected. What's more, though, is when we really look into the data and we see, okay, which communities are most at risk or most sort of least vaccinated, it's really families and children that are experiencing poverty. So if we look at the neighborhoods with the highest quintile of material deprivation, we see only 20% of children aged 5 to 11, so really, really low, have completed their vaccine series for COVID-19. When we look at children, the lowest quintile for material deprivation, so not experiencing poverty, it's higher, it's 40%. So there is a really significant differential. We want to focus efforts on all children across the province being vaccinated for COVID, especially as we move into fall, but with a special emphasis on these really high-risk populations where vaccination rates are so low. So children experiencing poverty, marginalization, similar trends for refugee families, newcomers, these groups we really need to think about moving forward.
Thank you so much, Dr. Freeman. Really appreciate your pediatrics perspective, leading with the data on how to protect a vulnerable population that indeed we have responsibility for. I really appreciate your perspective. Moving on, Dr. Petrosoniak, I appreciate you coming today. News headlines have been speaking of the strains and pressures in the emergency department. This is my clinical background as well. I feel as though we're colleagues in that respect. And there you are. So thank you for coming today. Also, just asking you now to speak to really the situation in the emergency departments and how going forward with the situation that's been described leading into the fall, COVID-19, where the pandemic's going, how to best be prepared.
Great. Thanks very much, Dr. Zacharias. And it's a pleasure to speak with everybody here today. I do want to just take a moment and shout out to all the colleagues in the Emerge and those across the system who are grinding away and fighting, what is pretty much an uphill battle. I don't think what I'm going to have to say here is overly positive. So, my apologies in advance for this. I think we're sort of in a situation that's quite unfortunate. And to be honest, all of the healthcare workers are really propping up and they're the reason the healthcare system, I think, hasn't crumbled. At least that's sort of my take. So, thanks for everybody that's been doing that work. And I feel awful for the patients who I'm going to talk about today, who are experiencing wait times like we've never had before. And I think, straight up a prediction, I think there's about a 99% chance that the emergency departments in Ontario will be worse in the fall than in the current situation. I'd want to say 100%, but I'm going to give myself a little bit of hope and hope that, maybe there's a chance that things are a little bit better. I can say through direct observation and speaking with colleagues, we continue, for those that come into the Emerge with life-threatening situations, we can still provide care and do so very well. I continue to be involved in resuscitations, and it's outstanding, and the staff are excellent. And despite the current state, they do an unbelievable job. But I think where I worry and where I think we're going to run into issues are the patients that come in who are not as sick initially, and they'll get missed, and something will happen. A bad outcome will happen, and maybe that's an unavoidable ICU stay. Maybe that's death. I don't know, and I think that might happen in a waiting room because patients are waiting so long. It might happen in a hallway because they're waiting, for hours to get to a place where they can actually get adequate care. And it might be because there's staffing issues or just systemic inefficiencies. I don't know where it'll happen. I suspect this scenario might be playing out right now as we speak. I do think it's probably important to outline that there's not a single problem, that if we just fix it all, everything will just be better. I think the staffing crisis certainly is one that has made headlines, and I do think it warrants being in the headlines because it really is critical. I think it's maybe overly simplistic, and I'll try and kind of lay out, where there are challenges in addition to that. I would say, I think like a first call, a first step would be recognition by government officials, by key decision makers, by everybody involved that has power to do so, is to call that we are in a crisis, and specifically in the emergency departments in Ontario. If I'm leading a trauma resuscitation, and I can tell you things go much better when I call out and say to my team, we're in a crisis, this patient is, blood pressure is very low, they're near death, here's what we need to do, then things go very, much more smoothly despite, the pressures that we're all feeling when we are all on the same page. The Emerge, I guess, is a canary in the coal mine, I think, for signaling dysfunction in the system. And honestly, we all want shorter waits in the Emerge. But by focusing on wait times exclusively, I think it's, to some degree, it's a bit like rearranging deck chairs on the Titanic. I mean, what we need is to focus on efforts across the system and look at, where can we support staffing in outpatient settings and in hospitals. And honestly, the reason the ED is in crisis is because the rest of the system is too. And so I'll list out a kind of, this is, my own observations and from colleagues, 4 kind of key areas, and there are more. I won't overly simplify this, but 4 areas where I think that we've really struggled. And number 1, obviously, I'm going to start with the staffing. And honestly, if you ask a hockey player or a hockey team to play an entire game on the penalty kill, down a player, what are the odds that the team wins? I mean, that's what we're doing in the emergency department, except we're not doing that for one game, we're doing it for a whole season. And so, is it any surprise how we're doing with wait times? And there are places with no nurses, there are places with no physicians, there are no places with no clerical staff, and it's it's a really sad state to kind of see this, and hearing emergency departments in communities that are the safety net closing. That's a travesty to me. We're seeing emergency department boarding. So that means that patients are staying in the emergency department, admitted, seen by physicians, nurses, but they have nowhere else to go. And so you can imagine how difficult it is to see more patients if you have all of your beds taken up with only 1 or 2 extra beds to see new patients. And it would be a surprise to no one that wait times will increase. And then there are, and this has also been, come out in the media, is the rising mental health visits. And I'll leave it to the folks that specifically deal with these situations to speak more to the causes. But ultimately, what we hear from patients and what we hear from our mental health colleagues in the emergency department are there's just no outpatient resources that they can access adequately in any timely manner. So I feel awful that we see patients with in a crisis from a mental health diagnosis who wait in our emergency department for 24, 48, 3, 4, 5 days sometimes. And then finally, the patients that just have nowhere else to turn, and they come to the emergency department, they need to be seen for some reason, whether it's the emergency department or not. I think they would have, if they had other options, they would love to go to them. If they had a family doctor, which, there is a shortage there. If they could access specialist services, but the specialists have wait lists that are, incredibly long. If they could, patients will come to wherever it's easiest, and it's becoming increasingly difficult, but we still remain the easiest option. And so the current state of the ED, I don't see it improving in the short term. I think I would love to, us to lay out what are the challenges first, really understand the problems, and then start to make meaningful small improvements, because I think over time we can do that. And I'm optimistic that can happen. I'm just not optimistic in the near term that happens.
Thank you so much, Dr. Petrosoniak. I appreciate your perspective, the credibility of your lived experience, and speaking to the extensive strains and stressors that is our reality right now. So I appreciate everyone in the room. I know your questions have been coming into the chat, and at this point, and that's where you can put them to have them be addressed. If we don't get to your questions in due time, the media team will follow up with you. You can also email media@oma.org with additional requests for interviews following this media briefing, and we will have a recording of this session available later this afternoon. But at this point, I think we'll turn it over to questions, and Emily here at the OMA, I think you're taking us through the queue of them.
Thank you very much, Dr. Zacharias, and thank you to all our panelists today for participating. We've gotten a lot of media questions. The first one we've gotten a few times. I'm going to address this to you, Dr. Petrosoniak. This one's from Lizandra Ongarato at the MDC Media Group, and it was asked as well by Holly Mackenzie-Sutter from the Canadian Press. You've touched on this in your talk just now, but I'd like to ask again, given the state of hospitals at the moment, how equipped are hospitals to handle a fall surge of COVID or other illnesses, and what are your concerns?
Great question. Emily, can you hear me a little bit better now?
Yes,
okay?
yes.
Okay. Yeah, I mean, I don't know how I certainly can't comment on how well equipped a hospital is to do this. I mean, I expect that they should be. I mean, as physicians and along with my colleagues in the emergency department, we, will continue to provide as best care as we can, but, it's becoming increasingly difficult when there's no beds, when patients have to wait longer, and that, creates its own challenges of patients, become angry, it's becoming a harder place to work. We're seeing violence against healthcare clinicians like we've never seen before. So no, I'm not optimistic that things are going to be easier. I think that we will continue to provide very good care for patients in life-threatening situations, like I mentioned. I worry about those who it's not so apparent initially, and I'm sure things will get missed. I think that that's almost a certainty.
Thank you for that answer. We're going to move on to the next media question. This one's from Pauline Chan with CTV News Toronto, and it's directed towards Dr. Sloane Freeman. Dr. Freeman, you mentioned the extremely low vaccination rates in marginalized children. What recommendations do you have to reach out to those groups?
Yeah, I mean, it's a great question. It's a hard question to answer. I think the issues there are complicated. Usually when we think about vaccine uptake, it's about equitable access and also concerns around, vaccine confidence or vaccine hesitancy. And so different ways to address each problem. Maybe vaccine confidence is even more sort of complicated and multifactorial. I think, if families have a primary care provider that they know well and that they trust, probably the best place to start is there, because there's already a relationship, and a good conversation sort of around concerns is so key. But also around, equitable access. I think that public health units across the province have really done a good job in trying to reach sort of underserved, more marginalized populations, but it's very difficult. So sort of thinking about creative solutions about, how can we make this easier? How can we bring vaccines even deeper into the community where children are? I mean, school-based programs is one idea, since children are there, and that would be feasible and convenient for families. But it's a complicated question, but certainly one that we need to address quite urgently.
Thank you very much. And the next question is for Dr. Zain Chagla. When should people get their flu shot? Is it okay to get it at the same time as a COVID booster?
Yeah, it's a great question. So I would suspect our flu season is going to start after Thanksgiving. So getting it kind of at that point when it's first offered, making sure that older adults as well are accessing the high dose flu vaccine as part of their series as well. The good news is they can be given at the same time as a COVID vaccine in that sense. Other than the smallest children, the 6 months to 5-year-olds, where the COVID vaccine is just relatively new, they want to space things out for a couple of weeks. And the only reason for that is just if there are any adverse events that they kind of know which vaccine is attributable. But there's been lots of experience for other groups with the COVID-19 vaccine and the flu vaccine, and so they can be co-administered as reasonably as possible in that sense. So absolutely, people should be thinking about their COVID booster, but as well thinking about their flu shot. And again, don't delay once they kind of come out to the market in that Thanksgiving region.
And I've got another question from the Canadian press. This one's for Dr. Sloane Freeman. How concerned are you about resurgence of vaccine-preventable diseases like polio or the measles, et cetera? And what's the best approach to getting students caught up? Should it be public health units giving people more time to get the shots, or starting to enforce things like suspensions?
Yeah, great questions. No, I am concerned about, reemergence of vaccine-preventable diseases, like what we're seeing in New York City, even in New York State. So far, I know Canada is just sort of starting to test wastewaters. I don't believe there's any evidence yet within Canada, but it's definitely a real concern. So I think that our efforts really do have to be on children completing their immunization series, and certainly starting it if they haven't. In terms of suspension, so yeah, I mean, with the Immunizations of School Pupils Act. Most of these vaccines are mandated for school entry, but we still have, a whole group of students or children rather that are not yet school age. So these vaccines are started in infancy. In the first 18 months, most of them are started, and there's a booster sort of right at school entry, 4 to 6 years. So in terms of suspensions, that would really affect, older school age children, but then there's this, younger group that aren't in school. And we need to sort of target them as well and focus on, how do we start the series? How do we complete the series before they get to become school age?
Another question from the media, this one's for Dr. Chagla, comes from Sandra Giannis from TVO The Agenda. Dr. Chagla, you mentioned expecting a flu season this fall, but influenza B seems to have disappeared. Does it matter whether we predominantly see A strain or B strain?
Yeah, it's a good question. And B strain tends to kind of attenuate the flu season. So it tends to be that tail for January, February, and March. And so it may be a positive thing that we don't see it. Obviously, it means that there's less influenza in the community at that late season, especially when healthcare is already being stretched. In terms of the vaccine, the trivalent and quadrivalent vaccines contain elements to influenza A and influenza B. So the good news is, regardless of whether or not B or A is circulating, we've already, the decision was already made in terms of what influenza derivatives are being put into vaccinations for this current year. And again, we'll cover H3N2 and H1N1, which are big influenza A species, and influenza B. So again, we might have a bit of a break at the end of our flu season, but everything else should be pretty much the same in that sense. And again, no issues with the vaccine.
Thank you. And the next question is for Dr. Petrosoniak. This one's also from the Canadian Press. Dr. Petrosoniak, can you elaborate further why you feel there's a 99% chance that the situation in ERs will worsen in the short term? For example, what's going to change between now and then that makes you confident that things will get worse?
Well, I haven't seen any indication that we have a solution to staffing, and we continue to have nurses, physicians, shifts go unstaffed. And we typically do see more of a larger volume. Dr. Chagla has already alluded to this. We will see a rise of respiratory illnesses that happen in the fall. So people will then come to the emergency department. And, people tend, obviously injuries happen in the summertime more, but people will come in with things that they've kind of put off because they've been away for summer and haven't addressed. And so we tend to see a rise in volumes, even if it's a small rise. When you've maxed out a system, any small increase will has a risk of really overwhelming it. And so I don't, I listed a few different factors that are contributing to the current state. I haven't kind of seen any clear solutions in the near term for those. So it seems like a logical argument to then kind of carry over that it will be not better and likely worse.
And a follow-up question this one's for Dr. Rose Zacharias. What are long-term solutions that the OMA is suggesting to fix some of the cracks in the healthcare system?
Yes, it's so important to turn, in this time of overwhelm and crisis, to a roadmap for strategic solutions that can be implemented. The Ontario Medical Association mid-pandemic did an extensive consultation across all healthcare stakeholders, as well as physicians and healthcare team providers inside the system and utilizers of the system, to know how do we get very strategic and put our resources towards the priorities that will make a difference going forward. We know as healthcare team providers that there were gaps in the system prior to the pandemic. And while we dealt with the emergency of COVID, no one's fault, but there were then excessive strains put on the healthcare system, such as a massive backlog of surgeries and procedures that we need to get caught up on, as well as we know we have always needed investments in mental health, long-term home and community care. And as well, primary care is the foundation of the healthcare system in Ontario. 1 million people in Ontario don't have a family doctor. They don't have that trusted relationship to help navigate, to walk alongside an individual with their chronic medical conditions like diabetes and heart disease, to do the preventative measures of cancer screening, and to help them navigate the system. We need to decrease the administrative burden on the physicians that are inside the system, because that is contributing to their burnout and taking their time and attention away from direct patient care. Every one of us on this call graduated our training with the intention and competency and skill to care for patients. And the system has put such expectations on physicians that it is hampering their ability to provide direct patient care. Dr. Petrosoniak has outlined it very specifically as to what's happening in the emergency department. He outlined his comments by saying the only reason it hasn't fallen apart is because there are compassionate, high capacity, committed healthcare givers inside that emergency department that are keeping it on its feet. And so I believe in the people who are wanting to provide good care, but it's the system issues that now need to be addressed. BetterHealthcare.ca outlines our roadmap to address these healthcare solutions. We're calling them our prescription for Ontario, and yet I've highlighted a few of them here for you.
Thank you very much. And Dr. Petrosoniak, another question for you. You've previously tweeted about the inefficiencies of electronic medical records and how that can be a burden to physicians. So tell us more about this issue and how it could be fixed.
Sorry, Emily, could you just repeat that question?
Yes, so we've seen on Twitter, you've spoken out about some of the inefficiencies in electronic medical records that physicians use and how it can be a burden to physicians. So can you explain a little bit about that issue and that burden and how it could potentially be fixed?
Yeah, okay. I mean, I think, first of all, this has been a problem that's been plaguing healthcare, not just in Canada, but across probably across the world since EMRs or electronic health records have been implemented. We're all faced, every single one of us on this call are all faced with using seemingly difficult platforms to navigate and to get access to patient records and all of that. I mean, click fatigue is really a real thing, and the ability to have to understand and use multiple different systems and is really quite challenging. I can't see what is in the chart of a patient who comes in. I can't see their family physician chart when they come into the emergency department. I have no idea what's been going on. I wouldn't know if Dr. Freeman sent in a patient from her office. I wouldn't know that. There's no transparency. It's a guessing game. And so that's incredibly inefficient for me to ask the patient. They give as best an answer they can, but I don't know what imaging tests have been done at outside institutions. I get lucky with this sort of patchwork system that's been put together to kind of backstop, inefficiency that's plagued the system for a while. But I simply am not able to access most records, on a regular basis. There's a lot of work that's happening to try and put this together. And Dr. Zacharias already outlined that this is something that, May is pushing forward as a key element. So I'm not an IT person. I'm a user. I make it as easy for me to see everything about a patient as possible, so that I can provide the care that they need. But tests get reordered because we can't access them from other institutions. So that's a waste of money. It takes longer for me to see a patient when I have to go through, different phone calls to family physicians' offices to try and figure out what was going on. All of these things add up. Maybe it's only 3 minutes per visit, but that over a course of a shift, that's incredibly inefficient.
And Dr. Zacharias, you've been very active in finding solutions for physician burnout. And maybe you can tell us a little bit about that work and some of the findings of the OMA's task force on physician burnout.
Yeah, the OMA has a bilateral burnout task force. So we are partnering with our Ministry of Health counterparts and have been glad to do that to address burnout. In 2021, we surveyed our membership, and burnout rates were at 72% of physicians saying that they're operating at levels of burnout. And that's not even to speak of the physicians that have now retired early and have exited possibly, or reduced as a family doctor, possibly reduce their practice in order to show up at work every day and provide the best care that they can inside the system constraints that they find themselves in. So burnout is real. It is that sense of exhaustion and fatigue. You can imagine dealing with 2.5 years of a pandemic, overlying even a previously recorded rate of burnout of 66% back in 2020, early 2020. So the administrative burden is the number one stressor that has been identified by physicians. For every 1 hour of patient care that a doctor provides, they are required to, they're 2 hours of administrative documentation that they do inside of these glitchy computer systems with drop-down menus, with viewfinders that you have to, navigate around the screen in order to read an entire sentence of a referral package that you are wanting to digest the health information of in order to provide good care for the patient that's sitting in front of you. And so reducing administrative burnout, physicians are often required to fill out a lot of forms, and that a doctor would do better providing patient care than the administrative task of in front of a computer screen or a pen in hand. And so we have to look at ways to alleviate that administrative burden. We have identified it as the main stressor. And just as been outlined by my Emerge colleague, it is in real time hampering our ability to provide good care for patients. And so we are committed to working with all levels of government to actually see these very specific recommendations through.
Thank you. And the next question is from Charlie Pinkerton with Queen's Park Briefing, and it's for Dr. Sloane Freeman. You've mentioned that the rate of routine vaccination in schools is now extremely low compared to pre-COVID. Is this at all because of how long children weren't physically in schools? And is this rate at all made up overall by how many children have received these kinds of vaccinations from other sources, like, for example, their family doctor?
Yes, that's a great question. So one of the primary reasons for this is because schools were closed for so long in Ontario, like longer than any other province or territory in the country. I think it was close to 28 weeks. So a long time, kids could not access the vaccinations at school. But I think another reason is that, public health resources had to be sort of redirected away from these school-based programs to COVID-19 vaccination efforts. So there's this obviously timely need to get kids vaccinated against COVID-19 at the same time as the routine immunizations. And so these school-based programs sort of slipped. So both reasons contributed to the really, really low rates. And yeah, it does include, so kids that may have gotten these vaccines elsewhere, so in community clinics or through their primary care doctors. So some may have started their series with primary care and then couldn't finish up at school. And then some students have been able to catch up through the community clinics. But again, these are hard to navigate, hard to access, especially for high-risk groups, for families that are marginalized. The school-based programs are great because they're obviously, when schools are open and when the resources are there, they're much easier to access. So I do hope that they continue, and I know that that's the plan.
Thank you very much. And another question for you, Dr. Freeman. This one's from Kylie Taggart. Do you think that pharmacists might contribute to delivering the school-based vaccines that children missed in grade 7 and 8? And is there also concern with 14-year-olds getting the Tdap?
So I think right now what public health has arranged for students to get caught up on those school-based immunizations or through these community clinics. So I'm not aware that pharmacists are involved in that catch up. I mean, it's an idea and it might be more convenient for some families, but right now the efforts in these community-based clinics to catch kids up. In terms of the second part of the question, our kids also so now under vaccinated for Tdap at age 14. And I think we're seeing that as well. And that's really a reflection of the fact that healthcare is not being accessed the way it used to be by children, by young families. Primary care being the sort of foundation and bedrock of our healthcare system is not being accessed the same way since the pandemic, and that's where kids are getting those immunizations. So important that sort of we think about how we can improve that for kids to catch up and get that at age 14.
Thank you. And the next question's for Dr. Chagla. At what point does someone require treatment for COVID-19? And about what % of people contract COVID will need treatment? And do we have enough things like antibody therapies and antivirals in Ontario to treat everybody who may need them?
Yeah, it's a good question. And again, a big reminder that this is part of the pandemic strategy and has direct effects on what happens to hospitals. If we can keep people out of the hospital with COVID, it's going to benefit everyone. Right now, there are 2 therapies that are available to patients for the early treatment of COVID-19. That's Paxlovid, which is the 5-day course of pills, and remdesivir, which is a 3-day course of intravenous therapy. The Paxlovid is obviously much easier to access because it can be distributed to a lot of peripheral pharmacies, and family doctors and specialists can prescribe it directly to the pharmacies as compared to remdesivir, which requires a specialized center to infuse it for 3 consecutive days. People who are at high risk of hospitalization are people that can access therapy. So people who are immunocompromised, where we expect that their immune response to vaccine are going to be poor, where if they test positive, even with 3 or 4 doses of vaccines, we want to make sure that they have the best possible outcome, should be accessing these therapies. People who are under vaccinated, so 2 or less vaccines, who have risk factors, who are over the age of 60, and then over the age of 70 is also considered within Ontario. And again, particularly people who have risk factors, who are over the age of 70, who have chronic diseases like cardiac disease, respiratory disease, diabetes, chronic kidney disease, etc. These need to be given quickly, and so it takes all of us to make sure that these patients have adequate access to testing, have access to a provider that can provide the drug, have access to a pharmacy that can give the drug. I will say, though, from what I understand from federal supplies, that there is a lot of this, and in fact, it's probably being undergiven as compared to overgiven in the communities. And so, again, a big effort to say that these are there, they're available, they should be used in the right patients, and they could have significant effects. A 90% reduction in hospitalization amongst the right patients who get the drug is something that can significantly benefit us going into a season where we may see a lot of COVID transmission. Finally, there is one more compound called Evusheld, which is being given to patients who have fairly significant immunodeficiencies right now, patients who are cancer patients, specific cancer patients, and solid organ transplant patients. That's an antibody that's given before getting COVID-19, almost like a vaccine. And again, the supplies are good. It's really just being able to administer it to the community as much as possible, and a lot of work being done to make sure those high-risk patients are reached and are offered a dose of this as well as their vaccines.
Thank you very much. And we've got a question from the Canadian press. This one's for Dr. Freeman. Are there concerns about a reported shortage of common children's pain reliever medication? How could it be addressed? And has there been an increase in children's illnesses that's driving up demand?
Yeah, so I just heard about this yesterday as well. It's quite alarming and shocking. I think it's going to be a huge problem. Kids get fevers, really, really common viral illnesses. All kids get fevers. And then what will parents do, after hours? How are they going to access prescriptions that now seem to be required for these over-the-counter pain relievers? I can only imagine, families are going to go to already overburdened emergency departments. The wait times are so long. It seems really inappropriate. They'll have to access urgent care after hours. And I think it's going to be a huge, huge problem for an already difficult healthcare system at this time. I don't know exactly what's contributing to the shortages. I don't think it's an increase in viral illnesses, perhaps supply chain. I'm not sure why.
Thank you for that answer. Dr. Petrosoniak, another question for you. Are emergency departments seeing a lot of COVID-19 patients, or is it patients admitted for other reasons that is behind the patient volume?
Yeah, no, I mean, Dr. Chagla has outlined sort of the current state of COVID in the province, quite well. There's obviously still COVID. We still see patients with COVID. There are patients admitted with COVID, but that would not be the large burden that we're seeing of, if you walk through the hallways of any emergency department in the province right now, and you did a poll, I would think that it's a substantial minority of the patients. These are patients that need care, that don't have COVID, that have other medical conditions, that either it's a natural course of the illness that is unfortunately happening, or illness that's been somewhat neglected, or they haven't been able to access over the last few months. But what current numbers of patients that I'm seeing, a handful, a shift, maybe a few, but not substantial numbers. No, these are patients that are admitted and taking up space in the hallways, and these are patients that have conditions that we've managed for a long time, but unfortunately, things are just getting worse.
Well, we've gotten through a lot of questions today, so thank you to all the physicians on this panel for your time. We're reaching the top of the hour, and I'm going to throw it over to Dr. Zacharias for some closing remarks. But before I do, I've seen a lot of nodding from the panelists throughout this conversation. Is there any final comments that anybody would like to add? Okay, well, I guess Dr. Zacharias, do you have some closing remarks for us?
Thank you, Emily, and thank you so much to my esteemed, committed, high capacity colleagues that are inside a system that has fractures, and we have outlined them here today. We have a plan to address some of these shortcomings. It will require a commitment from all external healthcare stakeholders, and we are committed to working with government to see our current state of overwhelm through at this stage in the pandemic, in order to push through our current season of strain and continue to provide the care to our patients, which has been our intention as physicians all along. As the weather gets colder and we move indoors, I'll remind everyone on the call to catch up on their COVID-19 shots and their flu shots, and to just practice those good public health guidelines that we're all aware of, and remind our children every day: wash your hands. If you're unwell, stay home, monitor your symptoms, be in touch with your primary health care provider, and to provide some good advice when you need it. We need to address the crisis, the wait times, the lack of access to primary care providers, the lack of access to family doctors in Ontario, and urgent action is needed now. I think you have heard that loud and clear from all of us, and the perspectives on the healthcare system as we each see it. So thank you so much for your attention and bringing attention to this. Indeed, we're in this together in our respective roles. And thank you very much for your time. Bye for now.